So Dr. Assis, I've got to know him actually quite well over the past few years. He's at Yale in New Haven. He's really a strong patient advocate. I think I want to say that. I've said that a few times about some of our presenters, but he walks the walk and talks the talk. He's been very engaged in the PSC Partners organization, among others, and other rare diseases. He also brings a fantastic expertise to autoimmune liver disease in general. And he'll be the first to tell you he's a lot smarter than I am. So that's one of the reasons we invite him here. So again, join me in welcoming again Dr. Assis. Thank you.
Thank you. Again, Dr. Lammert, it's way too early to get deep in here. And on top of which, I'm not quite sure about some of those statements, but I appreciate the sentiment. Thank you. Okay, so I think for the sake of time, we will go ahead and get started then, if that's okay. I've been asked to discuss what to expect after your diagnosis of autoimmune hepatitis. This will be geared not primarily, but certainly to a good degree on a newer diagnosis, what the medical and patient-related discussions might be, what the usual course of events is, at least from our standpoint, and certainly, hopefully, from your standpoint. And we certainly will try to leave some time for questions. In fact, this one of all, I hope, has the most interaction because many of you, or some of you who might have been recently diagnosed with this condition, have a barrage of questions related to this very topic. So I think there's no scheme we need to adhere to, but at least want to give you some information if I could. So we'll start with the case. This is a 68-year-old woman who reports new fatigue and arthralgias, which means joint aches and pains. She has not been exposed to any infections. She's not on any new medications. Her own history is remarkable for having a thyroid condition called hypothyroidism. And interestingly, there's a few people in her family with celiac disease. The physical exam doesn't show any signs that the liver is failing, for example, jaundice or other severe symptoms, signs rather, but she does come in with these symptoms. We'll go straight to lab work. Again, I don't want to jump too quickly, but I want to take you through basically the timeline and the journey for a new diagnosis. So you may know or may not know, but ALT and AST are two of the standard liver tests that are checked in any liver panel. A normal ALT and AST is typically less than 30. In fact, for a young person, it should be in the teens. You can see that this patient's ALT and AST are much higher than that, right, in the hundreds, 380, 250. We look also at bilirubin, which is something that's dramatically elevated in somebody who has jaundice, and fortunately this level is normal. And albumin, which is a protein, which is a marker of how much the liver can make in terms of protein. If it's very low, that's a concerning sign, and in this case it's normal as well, which is good. As always, there needs to be testing for different types of causes of liver injury, and viruses are very commonly associated if there is going to be a liver inflammation. So it's important to test that up front. In this patient, the virus testing was negative. Ultrasound imaging of the liver didn't show any growth, any concern for cancer, or anything like that, which is good. And so that led down the road to the diagnostics. And basically, this patient had elevated levels of autoantibodies. And again, I came a bit late yesterday. I don't know if this had been discussed earlier, but most patients with autoimmune hepatitis have some signs of self-reaction, as we talked about a little bit yesterday. And autoantibodies are antibodies made in our body that are reacting against something in our own cells. And so there's several of them. Two of them called ANA, or anti-nuclear antibody, and SMA, or smooth muscle antibody, can be checked. They're not a diagnosis. They don't make the diagnosis, but they can suggest autoimmune hepatitis if they're elevated. And in this patient, both of those were higher than they should be. Lastly, there is a marker of the immune system called IgG, or immunoglobulin, and that should be normal in most of us, but if the immune system, again, is hyperactive, it can often be elevated. And in this context, it can suggest autoimmune hepatitis. And I put in bold there everything that was abnormal. As a clinician, I would look at this and say, well, we need to think about autoimmune hepatitis, especially in light of the symptoms that the patient came in with. Then a biopsy was done. A biopsy is the gold standard still to make the diagnosis of autoimmune hepatitis, no matter what the blood tests show, until you get that tissue, from my standpoint, at least for the diagnosis, it's hard to be sure about autoimmune hepatitis. Follow-up biopsies are not always necessary or recommended. That's a different topic. But to make the initial diagnosis, a biopsy is very important. And if you look at that slide there from a liver tissue, from a biopsy, you can see that there's little blue dots in higher numbers than perhaps there should be. Those are all immune cells, lymphocytes, T cells and B cells, plasma cells that are there causing inflammation. Normally there you see very little of that. And so this patient had active interface hepatitis, which means that the immune cells were directly interfacing with and attacking the liver cells. There was a lot of lymphocytes, plasma cells, and then also importantly, there was some degree of scars already from the outset. Probably that took some years to develop, but by the time the patient came to medical attention, there was already a fair amount of scars, also known as fibrosis. Here's a close-up of a biopsy. The liver cells are these larger cells with the pink appearing context or cytoplasm, and you can see the bluer, smaller lymphocytes there. Again, these liver cells are not very happy because they're being attacked by the lymphocytes and the plasma cells. So this is exactly what autoimmune hepatitis looks like under the microscope. So, I mean, we're here at the Autoimmune Hepatitis Conference, and this is a classic case. So this patient was diagnosed with autoimmune hepatitis, came in with symptoms, elevated liver tests, elevated autoantibodies, which are not typically there, and then a biopsy that was classic, overactive immune system in the liver. This is autoimmune hepatitis. So now what? All right, so let's say you're there coming for a follow-up visit with the provider and having this discussion. You know, it's a whole new diagnosis. I have yet to meet a patient who was familiar with that prior to being diagnosed, right? So it's a rare disease, and frankly, we had a mindfulness study that we did about 1.5 years ago now for some of our patients, and one of the most remarkable things about the mindfulness program, aside from the fact that they enjoyed the techniques, which were very helpful, was that they actually sat in a room with 8 other patients with autoimmune hepatitis. It's the first time they'd even seen another human being with autoimmune hepatitis, right? So this is not a diagnosis most people are familiar with. And I think, as already was discussed at the last talk, hepatitis is not always clear, you know, in the lay terminology. It's inflammation. The autoimmune part gets misunderstood a lot. It's not infectious, right? It's not alcohol related. It's completely your own immune system. So autoimmune hepatitis is foreign to most people when they're diagnosed, and we get that. We know that autoimmune hepatitis can sometimes present with a big explosion, so to speak, where somebody presents with acute liver failure. That means the liver is failing with very, very rapid and aggressive changes. But then we also know that even half or more than half of the patients have no symptoms at all, right? And their liver tests might be high, but they just went for a routine physical. Maybe before starting a cholesterol medicine, somebody wanted to check their liver, and there you go. It's been there for years and years without any signs, or symptoms rather. And then as the case of our patient, she came in with some not feeling well, fatigue, joint pains, and that prompted the workup. And for better or for worse, autoimmune hepatitis can present with any of these combination of events, and that's why it can be a challenge. One thing that it's good to already keep in mind here, and I don't have time to go over studies when this condition was first described in the 1950s, but it was observed prior to the fact that prior to the event of steroids being used, that about half of the patients, even with mild disease, would develop cirrhosis and eventual liver failure and death within 10 to 15 years, and much less if they had more active disease. So left to its own devices, there is a high risk of this condition causing cirrhosis and liver failure. And that's why we care about it clearly, because we want to preserve the liver and not get into that more dramatic situation. That's the whole point, of course. So when should we start treatment? You know, let's say you're in the clinic, you have autoimmune hepatitis. Beyond the fact of what is this and how did I get it, and those very appropriate questions, you know, what do we do about it? That's the next practical question, right? So we don't want the liver to fail. We don't want to need a transplant. We don't want to have all of these complications. So perhaps we should think about treatment. A very practical question is, who needs treatment, right? Does everybody need treatment, and to what degree? These are taken from the guidelines from autoimmune hepatitis, and these are pretty general, but just to review, if a patient has an elevated liver enzyme, ALT, especially a high level, that's an indication to treat. There's an active immune system there. If the biopsy shows significant inflammation or even significant scars, we don't want that to get any worse, and that is a reason to start treatment. And of course, if there are significant symptoms from the condition, as we talked about, this patient was not feeling very well at all, that is an indication to treat. Occasionally, this may not pertain to most of us, it is okay to just watch the condition, particularly if there's almost no inflammation, if there is what we call burned out cirrhosis, the fire has gone, there's no more fire to put out, and so perhaps not giving huge doses of steroids is the right thing to do, but that's a case-by-case basis. Most of the time, when we make the diagnosis, we do think that treatment is important and necessary to prevent the condition from getting worse. What do we try to do when we try to treat this condition? You know, what are we aiming for? It's reasonable to ask at the outset, and I think if that conversation hasn't been had, perhaps with the provider, it's a very reasonable question to have at any clinic visit, frankly. I think the broad-based goals here for treating autoimmune hepatitis are to control the inflammation, of course, as you can imagine, and to achieve remission. And we'll talk about remission a little bit more in the next slide. And then by doing both of those things, the best case scenario, what we always hope for, is for the scars, which drive a lot of the worsening of disease and cirrhosis, to actually have some time to heal. You know, the liver has an amazing ability to regenerate. And up until a very late stage, if you can control the underlying condition, the chances of those scars eventually getting reabsorbed and getting better are quite good. So that's really what we're aiming for in the big picture. So when I say remission, you know, people often think cancer because that's a word associated with cancer. We're not talking about anything related to cancer here, of course, but remission in the context of autoimmune hepatitis, you could think about it two ways. The more common one is biochemical, which means that the labs, okay? We can usually tell if somebody is in remission by checking their blood tests. The two ones that are commonly looked at are ALT, again, this liver enzyme that's part of any liver panel, and then also if the patient had high IgG or immunoglobulin levels initially, then we want that to get completely normal. That's another indicator of the immune system. If those two labs, which can be checked just with a regular blood draw, normalize and stay normal, then I think it's fair to say that a patient is in biochemical or blood-based remission. Okay, and how long it takes to get there can vary, and we'll talk about that in a little bit. And then there's a smaller number of patients who, if you do a liver biopsy at that stage, might have a little bit of inflammation yet. Not everyone, in my opinion, needs a routine biopsy to check to see if we're in remission. But histologic or biopsy remission means that if you did another biopsy, you wouldn't see any inflammation at all. Practically speaking, for clinical purposes, checking labs is the main way that we can see if somebody's in remission. So this patient, again, the patient that we started off with, was offered treatment with prednisone, 30 milligrams a day, and azathioprine, or Imuran, 50 milligrams a day. And she had some insomnia. I mean, it's been discussed, some of the side effects, and we'll go over that a little bit more. But overall, she was able to tolerate the regimen. This is a table from the guidelines from autoimmune hepatitis from the Liver Association in the U.S. One of the things that I just believe in is that, you know, we shouldn't take this as clinicians, at least, as being cookie cutter and, you know, standard and overly standardize this. I mean, we do need standardization clearly in practice for these patients, but I certainly don't like to see people exposed to more steroids than they need. As we know, weight gain and other complications can be profound, right? And of course, we also don't want to undertreat. So it's a fine line often, knowing how much medication to give. But just to review the very basics here, if you notice that these tables, if the treatment starts with steroids only, as you can imagine, the dose of steroids is a little bit higher. And if you start with prednisone and azathioprine, the azathioprine is there to kind of do some of the heavy lifting and allow us to treat with less steroids. So it's meant to reduce the reliance on steroids in order to get into remission. And there are some suggestions or guidelines there for what to do at different weeks. I think every case is a little bit different, but these are general rules of thumb in terms of how to start treatment. So first-line treatment then for a new diagnosis of autoimmune hepatitis would be to start most likely a combination of steroids and azathioprine. How about what we could expect to happen? That's reasonable to ask, right? And so about 80% of patients will respond to glucocorticoids or prednisone and azathioprine. And clearly, compared to some conditions for which we don't have any treatment, or other ones that have a very low rate of success, up front at least, this is a pretty good odds of success. And so we certainly like that. And how much would we treat? Until when? Well, at the very minimum, until there's biochemical remission, normal ALT, normal IgG, and probably that should be the case for at least 6 months, realistically 12 to 18 months, on some combination of doses. I mean, I think we'll talk about relapses in a few minutes, but we want to make sure that the immune system is completely quieted so that that injury to the liver goes away, and again, it gives us some time for the liver to heal. By getting normal liver enzymes and IgG, we hope that we can also reduce the risk of a future relapse, which we'll also discuss. However, we don't have time to go into all these details. The real-world data suggests to us that in the end, to get to full remission, it's about 60% of patients. And you can imagine there's a fair number of patients who don't get to the end goal with the initial treatments. And so this is where these alternative medications come in, and what do we do next? I think there's been enough discussion of side effects. I don't have to go into too much detail, but certainly we can discuss it later. This is, again, a table coming from the ASLD guidelines. I mean, steroids, as you may know, over time can cause significant weight gain, can predispose to diabetes, can actually even cause some fatty liver, frankly, as well as effects on mood, depression, anxiety, as was just discussed. Azathioprine is generally a safe medication, but there are some potential side effects to that as well. About 5 to 10% of patients who start that medication, azathioprine, will get sudden nausea and vomiting. You can't really predict that, and I just tell patients, if, God forbid, that's your case, stop it immediately and you'll be just fine. It's just that you didn't tolerate taking the medication. There's a more concerning side effect that's quite unusual, is that it will be toxic to the bone marrow, and that's something that we watch out for. And again, it's very unusual, but if somebody's predisposed to that, which you can check with testing, then somebody should not receive that medication. But by and large, people can remain on azathioprine. And again, from my perspective, it helps to reduce the need for steroids, and that is its role. Long-term, something that might be relevant perhaps to people who are on medications for years, it can slightly increase the risk of skin cancer. Not melanoma, not the type that can invade and spread throughout the body, but localized skin tumors. And certainly it is important to take care of your skin and to have dermatology or skin doctor visits if you're on this treatment every year or so. Quality of life, I just discussed that, I think, earlier upstairs, and if you were there, but the real world data from the UK and even from here as well, as you can imagine, shows that steroids impact our quality of life. Interestingly, they have an impact on quality of life even at low doses. So although we're very happy to be on a low dose because it's better than a high dose, even low doses of steroids have some side effects. So if you're having a new diagnosis of autoimmune hepatitis, you realize that the goal is to get into remission, and there's a need to treat in order to do that. It's important to be a little familiar, or at least to monitor your own body for some of these side effects. And we all try, and Dr. Lambert and the group here do a great job, and as do other centers around the country, to try to meet up front the impact of this on quality of life. There's a lot more that needs to be done, clearly, but these are some of the realities of being on treatment and of having this condition. What else should be done for a patient who has a new diagnosis of autoimmune hepatitis? There are certain viruses that can infect the liver, such as hepatitis A and hepatitis B. Fortunately, these are viruses for whom we have very good vaccinations, so getting immunized against the risk of infection for these viruses is important. It would be silly to risk perhaps getting either of these infections if you already have an ongoing liver condition. So getting vaccinated for hepatitis A and B is standard and important. We know that not only autoimmune hepatitis, but the steroids that are used to treat autoimmune hepatitis can thin the bones. They can lead to osteopenia, which is a milder version of bone thinning, and then osteoporosis, which is a more significant form of bone thinning. And so standard practice would be to check a bone density scan, something that after menopause is routine for women, but even patients who are younger should be tested for this in the context of ongoing steroid use. We've had a lot of discussions about vitamin D and supplementation. Clearly, vitamin D is important, especially if there's a risk for thinning of the bones. So bone health is something to keep in mind after a new diagnosis of autoimmune hepatitis. So if we get back to our case here, so 8 months later, the patient's profile is as seen there. Her liver enzymes are better than they were, right? They were in the 300 to 400s. But I would consider an ALT of 65 units per liter to be a little bit higher than I would like to see. In other words, it's some control, but not perfect control. The immunoglobulin level is also a little bit higher than I would like it to be. And this patient is on 15 milligrams, so the dose has come down, but it clearly hasn't gotten to less than 10 milligrams. And you can see that the dose of azathioprine has gone up. And she's gained weight from steroids and is not happy. And that's fair, because we have to work with the whole person. This is not a numbers game, it's a whole body improvement. And so I would say that this is not the scenario in which all patients find themselves. I could have easily presented a scenario in which at this point in 8 months, the dose of prednisone is quite low, maybe 2.5 or 5 milligrams. The azathioprine is at a more modest dose, and the enzymes are pristine. When that happens, which happens quite frequently, and I'm happy about that, we just stay the course. We continue with treatment for at least another year. I think it's reasonable to discuss treatment withdrawal at some point if the patient is highly interested, not if somebody presented very, very sick with life-threatening autoimmune hepatitis. But certainly there's a discussion that can be had about that. But getting initial control within 6 to 8 months is important. I'm just presenting here the other option, or the other alternative, is in which we don't have perfect control, good, but not perfect, but at also the expense of side effects, because this may or may not be your case, but it certainly is a possibility to be aware of. So now what? Well, we don't have, again, as many large studies as we would like for this condition, but one study that was published about 6 or 7 years ago gives us some direction as to what we should aim for. If a patient is on ongoing treatment for autoimmune hepatitis, and yet their ALT, their liver enzyme, is still elevated despite ongoing treatment after a year, this suggests that the disease might be more difficult to control and puts the patient at risk then for liver progression, for cirrhosis, liver transplant, and other problems along those lines. And so I do start to get antsy, or at least to get a bit more concerned if we're not achieving success, getting closer to that 6 to 8 to 12 month range. And so this is maybe part of the discussions with you and your provider on this regard. Why do we care about this? I'm not going to go into too much detail. I believe there's a lecture coming up later this morning on this, but just to reiterate what we're really getting at, the meat of this with ongoing inflammation is progression of scars or fibrosis. Accumulating too many scars as a result of ongoing inflammation is what we fear the most, because that, in its more severe form, is the definition of cirrhosis. You can see here between F0 and F4 how there is a bit of a progression in the liver, just the cartoon there, between stage 0, stage 1, stage 2, 3, and 4. And what we don't want is to start with the stage 2 and get to a 3 or 4 over time. We don't want to start with a 3 and get to a 4. We want to really stop it in its tracks and hopefully get better over time, which is really what we need to aim for. And ongoing inflammation, or untreated inflammation, is that risk factor that can lead to more scars being deposited over time. We won't spend much time on tissue, but just to reiterate, you can tell sometimes whether there's scars on a biopsy, different degrees, and also this will be the topic coming up, so I won't spend any significant time on this. Now we can monitor the degree of scars using non-invasive measures, such as a fibroscan or an MRI elastography. So as opposed to seeing where we are with scars, we can sometimes do some more fancy tests now that don't require puncturing the skin with the biopsy. But again, to drive home the point, ongoing inflammation matters in autoimmune hepatitis because we think it will significantly lead to a risk of more scars. So that's really the end game here. There's only one publication, or one or two so far, on the use of FibroScan in autoimmune hepatitis, but a group from Germany recently showed that it can be helpful. So in my own practice, we talk about what to expect next from this disease. I monitor for the degree of fibrosis or scars almost on a yearly basis, every 12 to 18 months. Without having to do a biopsy each time point, having a FibroScan done can be very helpful. And we hope for stabilization and improvement. This is a very nice study from about 20 years ago proving that point. The more blue on this type of staining, the more scars or fibrosis. And if you look at your left-hand side, that column there, these are 3 patients who were diagnosed with autoimmune hepatitis. And after successful treatment and being in remission for a number of years, they actually re-biopsied these patients. And you can see the corresponding slide in that column there. Look how there's so much less blue afterwards. So it is known, and we always aim for not only just a stabilization of scars, but actually a regression, an improvement in scars. The liver, until a very late stage, is typically able to improve its degree of scarring, and this is what we aim for here. Now, in the case of our patient, the standard treatments weren't getting the job done, and they were associated with side effects. We don't have time to go into all of the alternative medications, but there is a whole list of them. We don't certainly have enough data to have a single go-to, and it depends on each patient. Budesonide is a steroid that stays mostly in the liver, which we can talk about more if there's interest. Cellcept or mycophenolate sometimes can be used. It should not be used in the possibility of pregnancy because it can cause birth defects. 6-MP, which is a drug used typically in patients who have colitis, inflammation of their colon, has been used, as well as cyclosporin and tacrolimus, which are medications that are typically used in transplant patients. Sometimes we reach for those if we're really in need. One recent study compared the two, Cellcept or MMF and tacrolimus, and found that for patients who really were not responding to the medications and were having ongoing inflammation, perhaps tacrolimus did a little bit better. But this is where individualized decisions with your provider are very important. This is not a one-size-fits-all. We don't like to talk about transplant and severe ongoing inflammation, but it's reasonable to at least address it. Fortunately, because most patients respond to treatment, the need for transplantation is not very high. In fact, out of all the transplants that occur per year in the US, it's estimated 5 to 6% account for autoimmune hepatitis. I prefer 0, but 6 is certainly better, and most patients don't get there. You can see that the 5 and 10-year survival is pretty good as far as post-transplant outcomes. Unfortunately, there can be a risk of recurrence of the autoimmune hepatitis in the new liver, which is interesting. It's somebody else's liver. Why is it there? Well, it just proves the point that this is your own immune system causing the trouble, even on a new liver. But fortunately, it's unusual for that new liver to get destroyed from the autoimmune hepatitis. We have ways to adjust the immune medicines after transplant to take care of that. So to conclude, getting back to the case of this patient, she was initiated on oral tacrolimus, not something that we would do ordinarily, but just giving a scenario here. Azathioprine was discontinued, and then the dose of prednisone was tapered significantly, which was the main issue with the quality of life. 1 year afterward, the patient was in remission, meaning normal ALT, normal IgG. And then 2 years later, by FibroScan, without needing a new biopsy, the degree of fibrosis, if you remember at the diagnosis, was a stage 3, so getting to that stage 4 level, it had regressed significantly to stage 1 to 2. Then the last question I'll leave you with is, should we now come off the medication? It's an individualized decision. It's a discussion that should always be had with your provider. What we will refer to in our minds, perhaps, though, is some of this data showing that within 2 years of stopping all medications, even in patients who were in biochemical remission, 70% of patients had a relapse. So what it means is that even if you're doing very well, even if the disease is well controlled, don't disappear. I tell patients, even if we check your labs just a few times a year, it's good for us to keep an eye on things because we don't want a late relapse. And I think that's always good to bear in mind. If we monitor, even with low doses of medications, we can do everything possible to prevent this. So do you have any questions at this point about new diagnosis or things that would be on your mind or have perhaps recently been on your mind as related to a new condition like this?
So we can definitely take some questions. We we also have a break now, so maybe if you want to feel free to get up. I'll say we're going to put Dr. Assis and Dr. Weinberg a little bit more on the spot too in our next session.
Oh, good. Yeah.
Kind of more, you're the doctor. They're going to be our training wheels in some sense.
Hello. So recently, my physician at Northwestern University mentioned to me that they received a grant to do a study with T cells. So she said that they would extract our T cells, isolate them, I don't know, multiply them maybe, and then put them back into our bodies to see if they could replace medication. After my next biopsy, she said that I could possibly be a candidate for something like this, but obviously I'm hesitant to be a test subject. So I was just wondering if you guys had any information about it and what your thoughts were.
Sure. Sounds like a very timely discussion. I just was talking about that at the upstairs session about an hour ago. So Josh Levitsky from Northwestern and his colleagues have a protocol, which we can discuss further as far as the topic here, but to expand what are called regulatory T cells and reinfuse them. Obviously it's still experimental, but certainly in theory a potentially promising way to take care of this to restore tolerance. And so, what I tell patients who come and there's a potential trial, there's different ways to discuss it, but one is it's certainly voluntary. There's never a mandate that is mandatory to be in a trial. Somebody should feel comfortable with the trial and should be convenient. It should have a lot of things that you feel invested in. Usually by definition, a trial like this is to see whether it works, and so it's hard to know up front what the results will be in terms of effectiveness. But the teams are very good, and I believe that team is also very good about doing everything possible to minimize the risks. And so I think as a concept, I'm significantly pro in terms of testing it. Whether that's the right trial for you to be in is a question. But I will say, the last comment on this is that we need more trials. We need to get beyond steroids, which are about 60 years old now. We need to come into the 21st century. And the only way we're going to really do that is by getting new studies and treatments. So whether it's one trial or another, I hope we can incentivize that. Yes.
If someone's asymptomatic and chooses not to treat their AIH, what kind of blood work monitoring and on what frequency would you recommend?
Yeah, that's a good question. So in terms of the guidelines, which are just that, they're guidelines, they're not meant to fit all, but somebody who has a near normal ALT, somebody who on a biopsy has no significant inflammation, that's the kind of scenario where in my mind it's reasonable to watch for a period of time to see how things go, so to speak. But in that context, it's good, to stay in the loop in terms of testing because we don't want it to take off at some point. ALT, IgG, those types of liver standard tests are the best way to monitor. And how frequently, I'd say at least every 1 to 2 months, no more than that.
Any other questions?
I just have a quick one on
Sure.
burned out cirrhosis. If your lab tests are normal and you have burned out cirrhosis, is that because of that? Or
Yeah,
what does
that's
that
a good
mean?
question. So, so burnout cirrhosis is probably meant to confuse as a term. I should have come up with a different word for it. But in medical terminology, what it means is that there's a forest fire in the liver. The liver got burned up to a degree. You see a lot of the scars and the ashes, but there's no more fire. So without a fire, in this context, you ask yourself whether you are benefiting or not from treating the inflammation if there's no more inflammation. So there is a smaller percent of patients who present and the damage has already been done and the scars are there, but there's no more inflammation to treat. So if it can be shown, and this is case by case, that it's from autoimmune hepatitis, then you can say, yes, for sure, the autoimmune hepatitis caused this. That would be the scenario.
Thank you.
Okay.